All right, good morning, everybody. It's 8 o'clock. Welcome to the Comparative Ocular Pathology Lab, Ocular Pathology Rounds on June 12th, 2024. I'm Dr. Jamie Miller, and I'm going to get started with the cases today. There we go. All right, so this first eye is the left eye from an 11-year-old, 9-month-old Dalmatian dog, female spayed. Comes with a history that they had a 360-degree vascularization and severe diffuse edema, presumably of the cornea, with 3 to 4 hemorrhagic flare. The IOP was reported as 62 with yes to glaucoma checked on our submission form. Other pertinent history is the remaining eye has an IOP of 7. Had retinal hemorrhages, and on gonioscopy, they noted a closed angle with a few flow holes present. So they were diagnosing goniodysogenesis in the remaining eye. This dog also has a heart murmur and chronic valvular disease. So grossly, it's a hemisective view of the eye. It was ophthalmic, so it was pretty big. Cornea is up here at the top. We've got lens here in the center, and we can see that the globe is filled with abundant hemorrhage in the anterior chamber, coming around here in the vitreous. This little thin yellow line here that kind of makes this little gull wing V-shaped is retina that has been detached. And there's a bunch of hemorrhage and some tan material here in the subretinal space. It was a little hard to appreciate what the uvea was doing with all the hemorrhage around. So we'll take a close look at that as well. So, here, let's see. I'm going to try to do a subgross here of the eye. Maybe. Yeah, keep the contents straight. Maybe I see it. I'm sorry. Well, we're gonna go without it.
For everyone at home, we apologize. We're having some technical difficulties with this microscope camera this week, so if it's less than ideal, bear with us.
Okay. All right. Then I will try to do a slow walk around the eye for you guys. So let me get myself oriented here. Little mouse in the middle. All right. We're going to start at the front of the eye. So here is cornea. It's a little bit more hypercellular than it should be. I'll walk around that. We got eosinophilic material and red blood cells in the anterior chamber. Here's part of the iris leaflet here, some ciliary body. Walking around the back, more hemorrhage in the vitreal space. So our choroid and our sclera back here. We'll keep moving around. We're not quite at the optic nerve head. Actually, I think we might be through it in this section, but this is where the optic nerve would be coming in here. And there's a bunch of hemorrhage. Here's our detached retina. Again, that little V-shaped that we saw grossly. And we'll move back towards the front of the eye. Here's the lens in the center. We didn't quite get a full section of it, but sometimes that happens during processing. And we work with it. So up front in the cornea, see if I can get this in focus. It's about as bright as I can get it. There we go. Aha. All right. Corneal epithelium here. Here's our stroma. There's blood vessels coming in here and some inflammatory cells, probably neutrophils, maybe some lymphocytes, plasma cells, to go along with the 360-degree vascularization that they noted clinically. Let's be back out here. Heading here to the iris here, we can see that there is a robust fibrovascular membrane on the surface. all these spindle cells here lining the anterior surface of the iris, come down here, cross the angle here, causing peripheral anterior synechia. When we have all this hemorrhage and all these fibrovascular membranes and the synechia, it can be really hard to evaluate the angles for goniodysogenesis, since that was what they had mentioned in the other eye. So unfortunately, with this case, we're not really going to be able to comment much on that. But the fibrovascular membranes do kind of extend out into the pupillary space here. Yeah. Try to multiple things to adjust. We've kind of got some flattening to the iris leaflet here, and the membranes kind of extend back onto the lens capsule. So supportive of posterior synechia as well. As we follow the lens around, it's going to be a little bit harder to see, but there is some cataractous change, some more ganglion globule formation, and some lens fiber degeneration. These cute little purple bodies here are asteroid bodies, consistent with asteroid hyalosis, that we can see with vitreous degeneration and sometimes with iridociliary tumors and such in the globe. So those are there as well. And then this right here is what is left of our retina. And we can see that there is, between here and here is what used to be retina. We can pick out blood vessels here that are part of the retina, and a little bit maybe of the outer layering here, but it's pretty necrotic. Too much there. Ooh. And as we follow it around, as we get back towards the central retina, we can see a little bit more of the layering here. But the other thing to note is kind of extending from this necrotic area of the retina into the hemorrhage, we do have these bland spindle cells that are occasionally forming blood vessels. So this is what we call a fibrinoproliferative lesion, usually extending from a necrotic retina. And usually when we see this in retinal detachment and the intraocular hemorrhage, we have a high suspicion or that systemic hypertension might be playing a role in this lesion. So we often will look at the blood vessels. Let's see. So here in the choroid and where the optic nerve would be coming in, these blood vessels here are really thick and kind of have irregular walls. Some of these smaller blood vessels are so thick that you can't really see the lumen anymore. So a couple other, so we have a sort of vasculopathy going on that again could be consistent with like a systemic lesion. I think I'm just going to put on a different section here. Find. Turn this down so I can actually see where I'm at. There we go. So this section here had more of the optic nerve head. It's very distorted by the detached retina. And again, just another look as you follow it out and it gets pretty necrotic. You see the blood vessel formation within the hemorrhage and the fibrin. So again, fibrinoproliferative lesion. And again, some of the blood vessels here in the optic nerve head and around the optic nerve are very thick and have irregular walls and no more lumen. The other, I guess, supporting information was that the other eye did have retinal hemorrhages as well, which would kind of help point towards a systemic lesion. So in this case, we had marked intraocular hemorrhage with a fibroproliferative lesion. We had vasculopathy in the choroidal and peripapillary blood vessels. Sometimes we can see it in the retina too, which is nice, but we don't always get to see those. And just because if there are no vascular lesions, it does not rule out potential systemic hypertension, because we do have cases where clinically they report history of hypertension and we do not see lesions. So again, putting all the pieces together, trying to help the clinicians for an underlying cause. And then, yep, lots of fibrovascular membrane formation with the retinal detachment and the hemorrhage in the eye, the cataract, and the necrosis in the retina. And we couldn't confirm glaucoma that they mentioned just because the retina is detached and with all the secondary lesions going on, but it would have been probably secondary to all the fibrovascular membrane formation. But again, with their clinical report of gonio-dysgenesis in the other eye, we aren't able to really evaluate that with all these secondary changes going on. And I think that was all I was going to say for this one.
Yeah, just for the clinicians out there, our diagnosis of systemic hypertension, that there's sometimes where they might come as a surprise. We think it might come as a surprise because it's not necessarily listed, but it's not an uncommon situation on our end. When we make that call, we're not necessarily making the diagnosis of systemic hypertension. We're basically throwing the ball back to you to make that diagnosis. An ocular biopsy would be the least direct way to make that diagnosis. And also, don't be concerned if there was one, systemic pressure measurement that doesn't fit, of course, for a definitive diagnosis of systemic hypertension. You need a more thorough examination in that.
All right. Next up is the left eye from a 7-year, 4-month-old female spayed border collie. And the history on this one is very brief and right to the point. They suspect blastomycosis. And that was all that was written down for the ophthalmologic findings. They said no to glaucoma, and it's been going on for a few months. The other eye is reportedly normal in this dog, and there was nothing else noted for the general medical conditions. So back to the globe. So cornea up here at the top. Grossly, we noted that there was a tan limboscleral bulge kind of ventrolaterally on the globe. And when we cut it open, there is this kind of white mass-like lesion here in the choroid. Everything else was looking okay up at the front of the eye. Lots of cloudy stuff in the vitreous and subretinal space. And then again, a kind of gull-wing V-shaped detached retina, a little bit of hemorrhages here. Let's look at this histologically. Okay. So again, try to do a walk around of the eye. Here's the cornea. Go up at the front here. Here in the center. Here we go. And as we walk around toward the limbus here, we can see where it gets very purple and pink and bulgy. So this is where the limboscleral bulge would have been. We've got this kind of light pink material here, which is all necrotic material. And then the basophilic stuff is all the inflammatory cells that have come in. And we can see again, pockets of necrosis surrounded by inflammatory cells that expand the choroid here. To head back towards the optic nerve. Kind of stops here. Again, retina is detached. It's kind of fun looking pattern here around the lens. And then the rest of the eye, There's iris over here. All right, so as we go back over here and we come look at our inflammatory population of cells, since they were suspecting blastomycosis. Go. Right. Closer here. So what, ooh, awesome. So we have lots of macrophages. Here, lots of neutrophils. And then we've already sort of landed on one organism here. See if I can get a little bit closer. It might be too dark for this. So we have a little yeast organism here with this really thick wall and a little basophilic center here, about 30 to 50 microns in diameter. Let's see here. Those are kind of found all throughout here. It's going to be harder for me to track these down. Oh, I can't see here. Okay. All right. All right. I'm looking for a very specific particular feature. Here they are. So get these in focus and get the light adjusted. Helps if I put my condenser in. One of the nice classic features for blastomycoses is they have this nice broad-based budding here. And so here's two little guys, kind of look like little snowmen. Right here, budding. Here's one that's not budding. And so these organisms are consistent with blastomyces. There are a couple, before I get too lost here in the clouds. This one had a pretty decent number of viable organisms in the sample. Here we go. I'm not sure this will pull up. Sometimes you only get dead ones or a lot of dead ones. And what is nice is sometimes that they will be surrounded by this radiating, in this case, basophilic material, and this is Splendori-Hopley material that kind of surrounds the yeast organisms. I think we're not entirely sure what Splendori-Hopley material is, but it's thought to be like an immune complex deposition seen in some infectious organisms, fungal, bacteria, maybe even some parasites. So it seems to be a immune reaction to them. So sometimes they can
foreign bodies.
and foreign bodies. So sometimes if you're having trouble finding organisms, because they're not always as readily apparent as they are in this case, which is why I brought it to rounds, that the Splendori-Hopley material can help highlight those if you're having trouble finding them. So again, necrosis, again, all the inflammation coming through our retina, again, is detached from the infiltrate of the inflammatory cells into the choroid here, kind of detaching it, lots of fibrin necrosis and such. And I think there wasn't too much else going on in the eye, a little bit of material in the anterior chamber. Might be a little preaurial fibrovascular membrane as well. Lining the front of the iris here. And again, kind of a little bit of a flattening to the back of the iris leaflet, so probably some posterior synechia as well. And I think there was a couple of guys here in the anterior chamber. Can start to pick those out a little bit clearer now that we know that we're looking for. All right. All this consistent with blastomycosis as they had suspected clinically. Was a severe pyogranulomatous and lymphoplasmacytic panuveitis, scleritis, conjunctivitis, and a little bit of endophthalmitis as it was going into the vitreous there. With those yeast organisms that are consistent with blastomyces species. We usually consider this to be kind of ocular manifestation of systemic disease, which they were probably already suspecting for some reason. But if they weren't, we usually tell them to look for it elsewhere in the body. In the ever important, no evidence of neoplasia for this case. All right, and those are my cases. And up next, we have Dr. Megan Clemens.
Hello. Megan Clemens. We have we have a pretty classic case here that we've already seen this year, but there's some interesting features of this particular case, and repetition is useful for learning. So this is the case of a 3-year-old neutered male Labrador Retriever Poodle mix. These eyes that are pictured here grossly are not this particular patient's eyes. This is a representative gross photo, but his eyes would have looked similar to this. So we have both eyes. This was a bilateral enucleation. And you see the right is hemisected and the left is hemisected, and they both look pretty similar. It's difficult to tell them apart. And the primary feature that we're looking at here grossly is this diffuse thickening of the uveal tract all the way around. Even the choroid is thickened. And it also looks a little bit more sort of tan brown rather than it's sort of more dark brown that you might expect. So something's mixed in there that's causing it to be thicker and to change color a little. So that's sort of the main thing grossly. Let's Okay. So I'll probably only show you one of the eyes. That one. Because they both look very similar. And we're going to fiddle with the light. Let's see. There we go. All right, so we're up here with the cornea on our right-hand side, and here's the iris coming into ciliary body, and we can see that there's an awful lot of purple in the uveal tract. And if we follow the uveal tract all around, it's still quite purple. Too many cells are here. And the purple is their nuclei and or cytoplasm. All the way around in the uveal tract. You can even see that inflammation is kind of spilling into the optic nerve head and the meninges and sort of the peripapillary connective tissue, which is not uncommon in this condition. Actually, while we're back here too, doing our full tour on the globe, you can see that the retina is relatively spared. Despite how severely affected the uvea is, retina doesn't have a whole lot of purple to it. Still looks like retina. And that's our full tour all the way around. We saw that diffuse thickening and inflammation in the uveal tract. Now, if we drop in on who these cells in the uvea are and fiddle with the light some, perhaps maybe go closer, maybe go even closer. Okay. All right, seems like it's probably the best we're going to be able to get it. So these cells are frequently macrophages, which are laden with melanin. So all of these round cells that have lots of melanin in their cytoplasm are melanin-laden macrophages. We certainly also have a large number of lymphocytes and plasma cells admixed among that as well. So this is actually an inflammatory population, and it's a melanin-laden macrophage-rich inflammatory population, which is similar all the way around the globe. If we dropped in on the choroid back here, we'd have pretty similar changes. Let's see, fiddle with the light some more. we go. Doesn't quite want to. All right. So again, melanin-laden macrophages, lots of lymphocytes and plasma cells as well. While we're back here on the choroid, you can also see this hypertrophy of the retinal pigment epithelium. The choroid is kind of cut in a funny plane, so you can see the next layer of cells basically behind the front layer. But they're all sort of tombstone shaped, sort of plump and hypertrophied, which implies that there's some degree of retinal detachment for real, a real in vivo detachment. But despite being detached, again, highlighting that the retina is relatively spared relative to inflammation, not very inflamed compared to the severely inflamed uveal tract. And those are the key histologic features of this condition, which is uveodermatologic syndrome, or VKH-like syndrome. So technically it's actually a VKH-like rather than a VKH. VKH in humans typically involves meningitis. In dogs, we don't really get the meningitis. Our cases, we more typically get a bilateral, and it's often bilaterally symmetric. So as we saw in this case, and actually the other case that we used for representative Groth's photo, both eyes tend to break with similar disease at the same time. And if you cut into them, they look kind of the same, both eyes. And we get the uveitis and don't as frequently get the dermatologic manifestation, which is usually something that involves inflammation and depigmentation around the eyes and of the nasal planum, so on the face, which is interesting. So that's uveodermatologic syndrome, but the reason why I show you this particular case is because there's some interesting features. So here are some clinical photos. Thank you to our clinician for allowing us to show these photos to you. And so this is our patient, and on the left we have an earlier photo, and on the right a slightly later photo post-enucleation. And you can see that already here in this initial photo, you're getting some depigmentation of the nasal planum, a lot of crusting and some inflammation. We've got some probable erosion to ulceration on the nasal planum here and more advanced depigmentation. The nose is basically completely depigmented. But then we keep following this patient out. Here again is that same picture on the left, now another later picture on the right, and we're getting advancing depigmentation over the face, so around the nose and around the eyes. And then if we keep following out, here's the patient later on again. And this is interesting. So the patient's, nearly the patient's entire face is depigmented at this point, but you can also see that the body is experiencing leukotrichia as well. And if you look at this patient, here's the entire body showing off this pretty generalized leukotrichia. This patient used to have black hair coat and now essentially has a white hair coat. And for reference, an earlier picture showing off some of the body as well as the face that was significantly different pigmentation. Do you know the timeline between the pictures, Lenny? I don't. I can't tell you the timeline between the pictures, but probably the clinician could, and I could ask. This patient eventually, this patient developed generalized leukotrichia following enucleation for VKH. And the reason why we have these pictures is there was this question of whether this patient may have vitiligo in addition to uveodermatologic syndrome. Apparently in humans, vitiligo has been linked to certain cases of VKH. However, the issue is that both are autoimmune conditions. I probably wouldn't change treatment options. Generalized leukotrichia has been described in rare cases of uveodermatologic syndrome, apparently in dogs. So it ultimately may be difficult to distinguish in a case like this whether this represents a case of uveodermatologic syndrome that is unusually generalized, or if this represents uveodermatologic syndrome coupled with vitiligo. And if anyone, part of the reason why I'm presenting this is if anyone has some insights or experience on cases that may have had uveodermatologic syndrome and developed vitiligo on top of that, we would be very curious. Let us know. But histologically in the skin, vitiligo may present with no inflammation and just depigmentation. And if there is no inflammation, it may be easier to diagnose. But if there is inflammation, there's melanin-laden macrophages in the skin, it would probably be difficult histologically to be confident whether it is vitiligo or VKH, even if we were to biopsy the skin. Just a very interesting and unusual case presentation in this guy. And if anyone has additional insights, we'd be very interested.
Billy Beckert Cohen here comment that looks very similar to a series of cases that Mitzi's office published on JAP in 2018.
Ooh.
Apparently, there was a dog that had was a brown lab that turned white within 6 months after enucleation.
Interesting.
Take a look at that.
And yeah, that is another interesting thing. So there's some degree of thought that in some patients, the enucleation of the eyes, like after enucleation, patients that may not have had significant dermal manifestations suddenly seem to have worse dermal manifestations, and it's unclear why that may be. So
We've had at least one.
interesting. A clinician in the room is saying that they also had a similar case. Yeah, interesting. Okay. In that case, we'll do the next case. Wait, yeah, okay, all right. So this is a 10-year, 8-month-old male neutered domestic short-haired cat. This cat has hyphema in the right eye, which is the eye that we have. The hyphema first appeared in January of this year and then resolved, but it is back in the eye again, more recently to enucleation. They also know that there is an iris and ciliary body mass in this eye, which we can see on the gross. And there is an additional interesting piece of clinical history, which I will retain for now and tell you later. So here's the hemisected globe. We've got a somewhat thickened and cloudy cornea. Here's our iris. And then here's the main event, this posterior iris, our iris base and ciliary body, and extending into the choroid, large mass, which looks sort of multiloculated or multifocal cavitations full of blood and has a tan to red appearance. We have retinal attachment in evidence here. And another interesting feature that I would point out is that the optic nerve looks quite thick and red as well. We also have a cataract, but that's the least of our worries. That's the gross exam, and we'll take a look at the histology. Probably won't be able to do an effective subgross, so we'll just take a tour around the eye like we did before. And it's probably too bright, eh? There we go. All right. Still too bright. Here we go. Okay, so here we are at the cornea, and we're going to walk back to where that mass was. Let's do it maybe a little bit brighter. So we can already see from low magnification here, we have our iris coming into this mass in the iris space and ciliary body. And at the edges of this mass where it's more viable, here it's all necrotic, just a sea of necrotic debris. We have neoplastic cells, which are indicated by the purple, and then a lot of these red spaces in between them, which is very interesting, and we'll take a look at that closer. Let's walk around the globe some more, showing off this necrotic mass. We're also here coming into choroid, which is very edematous and has these areas of neoplasia here as well. And then there we go, more viable neoplasia at the edge in the choroid. And then now that we're back here at optic nerve, oof, here we are with neoplasia extending into the optic nerve. We have compressed nerve parenchyma off to one side, just hemorrhage and neoplastic cells invading. And it's in the optic nerve meninges, extending into the orbital connective tissue around the optic nerve. And basically reaching edges. So that is a pretty extensive, invasive, and kind of ugly looking neoplasm. And we can see that the other side of the eye is a little bit less excited about it. So here we are, back at this area of viable cells in the mass. Let's take a closer look at these guys. Let's get it a little brighter. Here we go. Okay, and a little brighter still. Bear with me while I fiddle with this a little. All right. I'm gonna drop in right there and then leave it. All right, so we have these spindle-shaped cells. Rarely, they're kind of climbing along these very thin and delicate collagen beams. But mostly it's just these spindle cells that are delineating these little blood-filled channels between them. And these spindle cells are quite pleomorphic. They have quite large nuclei with prominent nucleoli. The mitotic count was quite high in this, which we'll see if I drop back into the optic nerve area, but we can see a mitotic figure here, for example. So this is a pretty pleomorphic and ugly looking neoplasm, which is made up of spindle cells that are forming around vascular channels. And if we go back to the optic nerve, and we can see some more of it, although it's somewhat similar. This is just an area where we have a lot more of our viable cells. Focus and brighter. Here we go. So kind of similar findings back here. But sometimes even just these solidly cellular areas, which are basically just intersecting streams of spindle cells. So another look at these really pleomorphic neoplastic cells. And then what I'll also show you real quick is if we zoom over here. So if you have neoplastic cells that kind of climb around or along, or even necessarily in the lumens of the scleral venous plexus, it's a little suspicious because you can get passive drainage of neoplastic cells essentially via the aqueous flowing through its usual pathways into some of these vessels. So it's difficult to necessarily confirm in those cases whether there's true vascular invasion or vascular involvement of a neoplasm. However, in this case, even some of these much smaller vessels further back in the equatorial to posterior sclera have clearly neoplastic cells in their lumens. So there are neoplastic cells in blood vessels here. And there's a suspicion of that going on in the choroid as well, although it's also distorted back there that it's difficult to be confident at that site. So this neoplasm is very interesting. It's not necessarily a nicely well-differentiated hemangiosarcoma, but I was very suspicious as such. And it is even more helpful to know that piece of history that I withheld originally, which is that this cat was diagnosed with nodal hemangiosarcoma some time ago in the neck or jaw region, and that was removed previously and has recently recurred at that location as well. So not only is this likely a hemangiosarcoma, but it is a presumptive metastatic hemangiosarcoma to the eye. Although it doesn't necessarily show clear metastatic patterns, the vascular invasion and the history are supportive of it. And this is a really unusual neoplasm to see in a cat eye. Very weird, a rare case, and also very upsetting. Not a nice tumor. So that's this case. We'll show the PowerPoint. There we go. And there we go. Any questions or comments on this case? Oh, actually, there's one more thing that I wanted to show you briefly before we move to the next case. It's not as exciting as the tumor, but this retina was completely detached. And what I wanted to show you was that this retina is also completely necrotic. It's artist formerly known as retina. So you can kind of still make out the retinal layers and its sort of vague shape, but it's complete coagulative necrosis. All the cells are just ghosts of their former selves. Just an interesting presentation in a necrotic retina. That's it. All right, now we can go to the next case. I would have been sad if I didn't get a chance to show that. Yeah. So next up we have Gillian Shaw, Dr. Gillian Shaw.
All right, good morning, everyone. All right, the first case I'm going to show is a bilateral enucleation, also known as a double scoop, from a 7-year-old Australian red heeler. We got very brief history, which included previously diagnosed with progressive retinal atrophy in 2022, so about 2 years ago, and also bilateral lens luxation and glaucoma. So here are both globes. The left globe is slightly larger than the right, so the ophthalmos is there is evident buphthalmos of the left eye. There are cataracts. You can see that the lenses are slightly opaque, and so any opacity in the lens equals a cataract. And then also, interestingly enough, the choroid, which should be more of a diffuse brown, at least in the atapetal area. I think this is the tapetum in this one, and maybe tapetum in this one over here. But in the pigmented areas of the choroid, there are these multifocal white spots, which I think is what prompted the gross photo. But I'm not really entirely sure who decided to photograph it. Anyway, so those are the main gross features. And now we will go to the histo. All right, so much like the gross photos, the histology of these globes is very similar between the left and the right. So there's, I will probably only end up showing one, and actually, I'm gonna go with the other one.
Oh, I got it.
When you drop that slide, don't move the chair,
You will hear a crunchy sound.
lest you roll over it and regret your decisions in life. All right. So, still a little too bright. Okay, so here we are at the cornea. In this area, we can see that the cornea is a little bit hypercellular, so there's some peripheral corneal stromal vascularization. There's also this sort of loose, kind of fluffy layer on the front of the iris. This is a pre-iridal fibrovascular membrane. And then there are also areas of purple in the iris stroma, which is consistent with inflammation. Similar story on the other side. We have that pre-iridal fibrovascular membrane and areas of inflammation in the iris. When we move back, so here is the lens capsule, and the lens nucleus is just displaced posteriorly. So here's the lens nucleus. These are intact lens fibers here, and then what we have is fraying and degeneration of the cortical lens fibers. So this is consistent with a cataract. I did not appreciate lens capsule rupture in either of these globes. And then as we move back to the posterior segment, there are these purple areas in the choroid, which are actually quite dark there. And then also the retina is very atrophied. And then if we go a little bit closer, closer to the optic nerve head, and here's the optic nerve head. They noted glaucoma, and certainly there was buphthalmos in the other eye, but the optic nerve head in this eye, in this particular area at least of this section, doesn't look very atrophied. So it was a little bit hard to confirm glaucoma in this case. Here is the retina on the other side. And we are missing some retinal layers here. So remember the first bit of clinical information I shared was that this dog had been diagnosed with PRA, or progressive retinal atrophy, which essentially means usually a genetic mutation in some gene that is relevant to photoreceptor health. So that can be a mutation in either rods or cones, or it can be a mutation in the RPE cells, which are essential for maintaining the health of the photoreceptors. We don't know which gene was involved in this case, and I'm not familiar right off the top of my head with which genes are affected in Australian cattle dogs. So I don't actually know what the gene would be. But anyway, so basically progressive retinal atrophy, depending on what flavor you're talking about, leads to loss of photoreceptors and then blindness. And sometimes, depending on which photoreceptor is affected first, sometimes you'll begin with more of a night blindness, which is something that affects the rods primarily, so that dim light vision is affected. And then often you will eventually, unfortunately, that also will lead to loss of the cones by some mechanisms that are not known to me. If the gene that's important is in the rods, but eventually the cones will eventually be affected as well. Anyway, so what we have here is the retina. And I was looking for a few ganglion cells that might be remaining, because it really was sort of hard to confirm glaucoma in this eye. All right, I believe this is a ganglion cell here. So here's our nerve fiber layer. Here's the inner nuclear layer, which are the second order neurons between the photoreceptors and the ganglion cells. So this is the horizontal cells and the bipolar cells, with probably some amacrine cells mixed in there. And then what we're largely missing in this retina is the outer nuclear layer, which is composed of the nuclei of the photoreceptors, the rods and the cones. So we are diffusely lacking that outer nuclear layer, which is consistent with the clinical diagnosis of PRA. When you have glaucoma in dogs, you will also, for the most part, end up with full thickness retinal atrophy of at least the ventral retina, and sometimes eventually the dorsal retina as well. So in dogs and canids, when you have glaucoma, it complicates the diagnosis of progressive retinal atrophy or outer retinal atrophy, because glaucoma itself can lead to outer retinal atrophy.
So Billy,
Yes.
Billy Becker can chime in here, said that cattle dogs develop rod cone degeneration,
Okay.
but they probably can have other options.
Yeah, I can't remember what gene is involved with that. And it probably varies. There's probably like 15 different genes that can cause
Right.
rod cone degeneration. I wanted to quickly show you the other eye, actually. Because, what's that?
We can talk about it. Okay.
Oh, good idea. Before I get there. So there is very robust fibrovascular membrane formation in this eye to explain decreased aqueous humor outflow and glaucoma. However, in one of these areas, and maybe another area as well, oh god, the scope is so annoying, more like the camera, we have this weird arborization of the end of Descemet's membrane, and it's sort of contacting iridoid tissue. So I was actually a little bit suspicious of goniodysgenesis in these eyes as well. I think it's a little bit difficult to confidently diagnose it based on the fibrovascular membrane and synechia formation, but I did suggest it. And in this case, with bilateral enucleation, it really doesn't matter whether it's goniodysgenic or not, unless this animal has been a breeding animal. And at this moment, she is a spayed female. So whether if she had pups earlier in her life, that might be relevant. But for the most part, it doesn't really matter whether we call it gonio or not, because both eyes have been removed. And normally clinicians need to know that, so they know whether or how to treat the remaining eye. So back to what Leandro mentioned, and something I need to cover is that both eyes have these very advanced cataracts. And for some reasons, dogs that have progressive retinal atrophy often go on to develop cataracts that can lead to blind. Well, they're already blind because the retina isn't working. But then they unfortunately develop cataracts, which then often leads to uveal inflammation, and then that will often lead to fibrovascular membrane and synechia formation, and then glaucoma. So even though you have a blind eye because of a retinal problem, unfortunately, they will often go on to develop glaucoma, which is painful. And so that will necessitate enucleation, which is probably what happened in both eyes here. The theory, as far as I have a rudimentary understanding of why cataracts develop in PRA, but I believe it has to do with dying retina, releasing things, cytokines and such, that are then toxic to the lens epithelium, which then leads to degeneration of the lens itself. I don't know exactly the mechanism there, and I also find it interesting because you can have an eye that's glaucomatous with retinal death, essentially, and that will never go on to develop cataracts. So I don't really know.
There's something intrinsic about the death of those. Yeah.
Yeah, so I don't know the exact mechanism. I've been out of that realm of
I think oxidative stress has been proposed as part of it. Yeah.
Okay, so clinician in the audience here said they don't see cataracts and SARDs, which has been one of my questions for a long time, and I've always forgotten to ask. Anyway, so
And that's a good thing for pathologists, because if you end up with a case where you have outer retinal atrophy, you, without any history, you won't be able to tell the difference between SARDs and PRA to a certain extent. But the presence of cataracts might make you lean towards PRA.
yeah, and good to keep in mind that both PRA and SARDs, these sudden acquired retinal degeneration syndrome, are bilateral. So if you get a single eye from an animal and you recognize what you're convinced is true isolated outer retinal atrophy, you might suggest PRA or SARDs, but usually those eyes should come with a history of blindness of both eyes. Depends on the quality of the history that you get, whether that's helpful. So anyway, so there we go. There are my diagnoses for this one. I just thought it was interesting to sort of discuss PRA and the connection to cataracts and possibly glaucoma as well. Oh yes, and so there was significant pan uveitis here, lymphoplasmacytic, which I assume is associated with the cataracts, as opposed to something else like VKH, but I did not appreciate the melanin-laden macrophages in this in the uveal tracts of these globes. And also there were plenty of remaining perfectly healthy looking melanocytes left in the uvea of these globes. So even though it's bilateral and lymphoplasmacytic, I didn't appreciate melanin-laden macrophages to suggest something like VKH. So there we go.
Another comment here, Amanda Romanek said that dialdehyde release from the dying retina has also been speculated as culprit for the cataract formation.
And then I ask, is there something specific about PRA death?
Right.
Or, I mean,
Exactly.
like, because you, as I said, we get retinal atrophy and death with
Ischemia,
plain
retinal
glaucoma. So,
attachment.
yeah,
That's cool. That's an interesting question.
yeah,
As Dr. D would say, there's a PhD there for something.
yeah. And actually, it's probably already been worked out. But
Right.
the real question is, why don't we see it in other cases of retinal disease? Okay, all right. I have about 6 or 7 minutes left to cover this one. This is kind of a quick one, I think. This is the left eye of a 1.5-year-old golden retriever mix. We got a history of severe chronic uveitis, suspected intraocular trauma. They say metallic foreign material, parentheses, suspected to be a shotgun pellet, found in the orbit and included in the jar. So they did not give us a duration of problem, except that she had diagnosed chronic uveitis. So presumably this is weeks to months, not days. So here is the globe that we received. The cornea is always at the top in our images. In this case, you can tell that the cornea is opaque. So there's definitely severe corneal disease going on. And there's also this off-white tissue that probably lines the back of that cornea and actually slips behind onto the posterior iris surface. The iris is up here and a little bit distorted. The iris on this side is kind of hard to identify, but I think this is it here. It is also quite distorted. Sometimes we call this a nubbinified retina, iris, or miniaturized iris. I've not heard other ocular pathology people use those terms, but we like them at Coplow. And also you can see that off-white tissue extending back onto the surface or around that iris onto the surface of the ciliary body here. And it also traverses the entire globe and it meets up with this area right here where we can see there's this nice focal discontinuity of the sclera and the overlying uvea. And that off-white tissue, which is fibrosis, I'll just tell you right now. So it's dense collagen with some other cell types mixed in. So extends from that defect in the sclera into the eye, and it kind of joins up with all that. So this is perfect for, unfortunately, a penetrating injury. They did actually send the pellet to us, and we said it was metallic and about 3 millimeters in diameter. And it was actually surrounded by tan tissue. So it had been in the orbit for a while, once again, along with the chronic history here. So there is that. That's the gross stuff. Oh yeah, and the lens is hard to make out here. There is the lens is ruptured. The lens material itself is hard to find in this gross photo. I think in this area there are fragments of the lens capsule. So let's go to our, I should remember to try to do this one a little bit quickly here. All right, we have two different slices of this eye. Here is one of the slices. This is the cornea. It is very hypercellular, probably with inflammation and reactive keratocytes. Descemet's membrane is very wrinkled and it's multifocally discontinuous. Here's a discontinuity here. And then that fibrous tissue is lining the back of the cornea. And as I said, it traverses all the way around the globe. At this low magnification, also, this is the peripheral cornea. And on the left-hand side of that gross image, where the iris was very dark, I believe this is either some sort of, it is a close to at least a site of rupture. I'm not sure if this is an entry or an exit point, but we have uvea prolapsing up into a defect. I think we just didn't get quite to the where it actually meets up with the surface of the eye. So there's definitely a defect here in the peripheral cornea. And then I'm going to switch. This is actually only a slice of the front of the eye. Now we're going to switch over to the whole globe. All right, so here's more cornea. So here is that dense fibrous tissue. As I mentioned, there's hemorrhage all over the place. Here is the lens capsule. And we have some pretty significant lens degeneration with some bladder cell formation and more ganglion globules. And we have some vacuolation of that lens material. So there's definitely lens capsule, rupture here. Which most likely occurred either because the pellet itself went right through the lens or because of the concussive forces associated with projectile, which is a form of ocular trauma that is both penetrating and blunt. So the force of a projectile hitting the eye can go through the globe, and then the sort of forces are sort of radiated out from that thing traveling through the eye at high speeds. Dog bites also can have similar things, although obviously they're not quite as high speed or quite the forces involved with a projectile. Anyway, so let's go on down here. So here's the optic nerve. I skipped over the actual scleral defect. Okay, just kidding. It might be on the other side. Unless it wasn't. Oh, hold on. I think we didn't quite sample it perfectly, but right here is it. So here's sclera. It's intact in this area, so we're probably just slightly adjacent to the actual rupture site. Here's the choroid that is discontinuous here, and then there's that dense collagenous tissue, or our fibrosis. Embedded within this fibrosis, we have fragments of degenerate retina. And then we also have some adherent iridociliary stuff right here. And then, as I said, that fibrosis kind of traverses the eye. This actually extremely dark purple stuff right here is actually mineral. So there's some sort of mineral here. Another possibility is that this could be a little bit of metal. It's actually, they sort of look similar, although it's usually not quite as purple.
Right.
It's usually just black on histologic section. And soft metals like lead can actually fragment. And so we could have ended up with a fragment of lens inside the eye. All right, it's about 9 o'clock, so I'll stop waffling on. So, and one other thing I wanted to mention is that with globe rupture, usually we will see uveal tissue or retina, whatever, outside of the eye. In this plane of section, at least, I did not appreciate retina or uveal tissue outside of the eye here, which might slightly suggest that the bullet was traveling in this direction. However, this is ventral because the tapetum is on the other side of this eye. And so it's a little bit hard to come up with how that may have actually entered the eye. So I'm not quite sure about the direction of travel. I am not a forensic person, so.
Yeah, there's a lot of things that need to be taken into account, which is hard because the bullets, the projectiles can change direction depending on what they hit first. If they hit the skin, if they hit the bone. So
Was the dog standing? Was
Yeah.
it lying down? Was it
lying
running?
down with that movement, directionality, but
Yeah. So anyway, here's our somewhat brief list of diagnoses. But anyway, just an interesting thing. So basically, whenever we see intraocular fibrosis, the first thing we often think about is that there was some sort of scleral rupture, either perforation or rupture. So whenever we see that, we start thinking about it and think like, oh, did we not sample something? You know, did we not identify it grossly and then get it sampled on the slide or whatever? But yeah, so whenever you see intraocular fibrosis, think penetration or rupture of the sclera. So that's all we have. Thank you for your attention, everyone.
You guys see you in a couple weeks.
Thank you.